greetings from Infertility Committee AOTD. Today we are going to discuss a very important topic, that is endometriosis. It is said that journey of the life is mysterious, but endometriosis disease is itself more mysterious than life. Endometriosis is still an enigma in all its aspects, whether it is etiopathogenesis, diagnosis, or management. So, to reach from confusions to a consensus, Dr. Pankaj Talwar sir with team Birla IVF has come together with AODD and IMS South Delhi branch to organize today's CME on endometriosis. We are blessed to have amongst us Major General Surinder Mohan sir as our chief guest, President AODD Dr. Achla Batra ma'am, past President AODD Dr. Mala Srivastava ma'am, President IFS Dr. K.D. Nair sir, President-elect Dr. Pankaj Talwar sir, past President IFS Dr. Kuldeep Jain. So, not only that, we have many of our esteemed faculties with us, that is Dr. Usha M. Kumar, Dr. Bindu Bajaj, Dr. Surveen Gumman, Dr. Shalini Chawla, Dr. Bandana Sodhi, Dr. Prachi Banera, Dr. Mansi Jain, Dr. Muskan Chabra. So, to start with the invocation song for the blessings of the God. So we have with us our chief guest, Major General Surinder Mohan sir, who is Dean Army College of Medical Sciences, which is the 5th in the private medical colleges. He is the pioneer of laparoscopic surgery who has trained around 30 laparoscopic surgeons. He has got more than 100 publications. He is one person who has initiated the training of paramedical staff in the army, and he was awarded the President Awards for his exemplary work in the field of laparoscopy. He has served for 35 years in various military hospitals and army teaching institutions. He is alumni of AFMC, DNB teacher and examiner of many universities. So we request you to give us words of wisdom. Sir.
I feel humbled to be in the presence of such august gathering and among my colleagues and also seniors. And when pearls, I can see pearls only with all these beautiful ladies, they have all the pearls. I am part of you. Yes, I was born early, that's alright. And of course, I was probably the first one in the armed forces to be selected for laparoscopic training. Way back, I remember in 95, the army wanted to have an endoscopic surgeon in gynecology, and that's where my journey started. And of course, it carried on and reached up to laparoscopy, reached up to the endometriosis, and what I recall is, what a mess. I mean, it begins with the beauty of life, that is, it begins with puberty and ends with menopause. What a bimari, what a disease. I mean, associated with the best period of somebody's life. That is why probably when they say that it's probably the price we are paying, the mankind is paying for delaying the natural instinct, nature instinct, that is procreation. If we are paying the price, and that is why the treatment is also deceiving the nature, that is, you create pseudo pregnancy, or you fight against the hormone which is the elixir of youth and beauty, that is estrogen. So you create an artificial menopause or pseudo-menopause or pseudo-pregnancy. That is what it is. Of course, then you have to treat the various morphological pathologies created by this particular disease, for which I think we are listening today to all the experts and about what all has been done. I remember in RR when I used to get so many cases of recurrent endometriosis that we realized that we got to find a solution to suppress it. And our experiment with oral contraceptive pills, that is, we used to call it 84 by 90. That means they were giving 4 packets of OCs, 84 tablets, and the patients were very happy because at least that painful period of a month has been reduced from 12.
Chairpersons of various committees of AOGD. She is a dedicated UG and PG teacher and also my PG teacher. She has concluded many research projects and has authored many books. Ma'am, we request you to please address the gathering.
Important these meetings when we deliberate on serious subjects and then have, chit chat and get together. So, and today's endeavor thought by Dr. Pankaj Talwar really brought us all together. And the topic, as Kavita said, is an enigma. We have about 25 million reported cases of endometriosis in India, but that is, not all. There are many more which are not reported. The younger ones would be told by their family that pain happens with everyone in periods, it's nothing new. Because it runs in family, their mothers or sister also might be suffering from it. And even if they are troubled, they would go to a doctor thinking that it will affect their marriage prospect. People will think she has some gynae problem, she will get married. Or joint family lady, if she thinks if she goes to gynecologist, they'll think that there's something wrong with her uterus. So people don't take treatment. On top of that, even I'm sorry to say that even healthcare providers also delay the diagnosis, thinking of this condition as something which is normal. Actually, very popular, especially in people who have not conceived as yet or want to be fertile still, but surgery has a definite role. Proper place. You should not remove part of ovary also. And when you're treating deep endometriosis, the rates of complications are pretty high. So you have to be really specialized in treating endometriosis. So today we are having a session on surgeries of endometriosis, and of course, about I think 25 to 40% of infertility patients have endometriosis. So the other lecture today about infertility in endometriosis is also very pertinent. So I think you will all take away very good points after this webinar, and we will all go very happy after meeting everyone also. Thank you.
Good afternoon, all of you. Warm welcome to everyone here from Birla Fertility IVF. We are just so honored to have you all here. Our chief guest, our guest of honor, luminaries, and all dear friends. So we have lined up 2 very interesting topics today for the scientific session, and followed by that, of course, some socializing, and then, of course, some accompaniment of chart and chai thereafter. Source of inspiration and a teacher par excellence. Sir is President-elect, Head Medical Services for Birla Fertility IVF, CEO of ICET India, Founder Secretary for Preservation, and you all know, awarded with VSM and so many other things to his credit. So please.
I'm an ex-army soldier, 30th in the Indian Army I have served. And then I have joined Birla Fertility and IVF and Medical Services. I'm an IVF specialist, but today I stand before you as Head Medical Services. As we open the program and we move ahead, heartiest gratitude to all of you, and heartiest gratitude to Dr. Kuldeep Jain, Dr. K.D. Nair, Dr. Achla and Kavita, of course, for giving us this opportunity to interact with all of you today. So I'm going to take you through a small journey of Birla Fertility and IVF.
Welcome to Birla Fertility and IVF.
We are a proud part of the 160-year-old Birla Group that has been solving India's healthcare needs for 50 years. Our vision is to make world-class fertility care accessible to all. Our team of fertility specialists have experienced 14,000 IVF cycles and are known for delivering exceptionally high success rates. With state-of-the-art fertility labs, best-in-class technology, and international protocols, we offer positive outcomes with a great patient experience. We understand that the needs of every couple is different. That is why our clinical team works with you at every step of the way to create a unique treatment plan that will work best for you. Fertility treatment is not just IVF, and that is why Birla Fertility IVF provides you with a comprehensive range of treatments for both male and female infertility, including diagnostics and cryopreservation. In line with our vision, we aim to bring fertility treatments within the reach of every Indian couple, and so our world-class treatment and care has been very attractively priced. We are aware that trying to build a family can be a very stressful time. In this difficult phase, you will find our team of doctors, nurses, and counselors as your friends. They will keep your safety and interest as their priority and guide you through your treatment with sensitivity and compassion. Above all, you will be assured of complete confidentiality and discretion in your fertility journey with us. So put your worries and fears aside and...
So it's a big change, as you can see. We have taken off our mask, our shields, our goggles, and we can share a small mocktail together and have some chat coffee today. So thank you so much again for joining us. And in case you look at the Birla Group is a $3 billion company which is present over 6 sectors over 5 continents. It's a big group, and this big group has got presence in the field of automobile industry. In case you all know, the first ambassador car, I think you would have all seen that, it was being made by Birla Group. And the ball bearings in the Chandrayaan were made by the Birla Group. Now gradually the Birla Group is entering the field of healthcare and fertility. Now some basics about how the fertility market is growing. When we look at it, we have around 20% growth of the fertility market all across the world. And this is the highest growing segment in the world in terms of healthcare. So in our country, we have low awareness, low affordability. That's the reason that a lot of corporates are coming into this now and trying to help people grow further. So our vision is to transform the future of fertility globally, not only in India. And it will be I'll show you a small vision which Birla Fertility has. So we intend to become the first #1 player globally in the coming 3 to 4 years. And our aim would be to open around 100 units all over the country and abroad. We already have 10 units open. In the coming 7 to 8 months or 10 months, we'll be opening around 20 units all over the country. We just launched our unit at Lajpat Nagar, and that's the reason we stand in front of you to make friends with you. Our value proposition is that we have to be clinically reliable, high success rates with tune of around 75%. We give a price promise and we have empathetic and trustworthy companion to all of us. We perform all the surgeries, all the type of treatments we give to the people, and we are a one-stop shop for any infertility treatment. So nurturing the people, being accessible to the people, being trusted, being optimistic and transparent is our motto, and our motto and logo is all heart, all science. हम जो भी करें दिल से करें और साइंस के अनुकूल करें. So we call ourselves all science, all heart. That's the motto of Birla Fertility and IVF. And once you look at it, our concept is that we always say we are part of Birla Fertility and IVF. And IVF comes later. We want to give people holistic care and only when indicated to carry out IVF. A small video of our IVF units which we are making all over the country. We got a similar pattern of IVF units all over the country and pan gold. So this is a routine reception of all our units. We believe in making very aesthetic and tastefully done IVF centers are being created. The top of the infra and top of our equipment is our promise. a small tour through the reception and the waiting area, and we have all the best possible equipment which you can procure sitting in India. So this is a glimpse of the Lajpat Center. A few pictures I'm showing to you. This is the waiting period, the waiting area for the patients. This is a routine. Thank you so much.
I would now like to invite our chairpersons. Tricks, surgical management of endometriosis. So for the chairpersons, we have Dr. Mala. Dr. Mala is a senior consultant and professor, gynae endoscopic and robotic surgeon at Gangaram Hospital, vice president-elect ISOPAR 2023-24, past president AOGD 2021. And ma'am's special areas of interest are gynae onco, gynae endoscopy surgery. Her special training is from Strasbourg, France, and she's got so many awards and accolades to her credit. Ma'am is also chairperson of Cervical Cancer Awareness and Prevention Committee, AOGD. So ma'am, please come onto the dais. Next, I would like to invite Dr. Usha Kumar ma'am. She is MBBS FRCOG, diploma in advanced endoscopy from Germany, principal consultant gynae, endoscopic and robotic surgeon. She is also the course director gynae endoscopic training at Max Super Specialty Hospital. Welcome, ma'am. She's been awarded many awards. She's conducted more than 1,000 endoscopic surgeries. So we have another illustrated chairperson here with us. Then Dr. Kavita Agarwal, ma'am. She is associate professor. Please come to the dais, ma'am. She's associate professor at Safdarjung, chairperson infertility subcommittee AOGD, vice president IMA. She's trained in infertility from Rainbow IVF and ICED. She has got more than 50 publications to her credit. She has been super active as an academician, 17 papers, poster presentations. So, and more than faculty at more than 100 conferences. So welcome, ma'am.
Endometriosis is a multifaceted disease, and as it occurs in the reproductive age group, so mostly the patient complains of pain and self-fertility. So here the surgery is mainly to preserve the reproductive function. Also, we see WHO recently said about endometriosis surgeries as all surgeries to preserve, conserve and improve the reproductive function. So to know about the tips and tricks on surgical endometriosis, we have with us Dr. Kuldeep Jain sir and Dr. Mansi Jain, who are going to take us from grade 1 endometriosis to grade 4 endometriosis. So I would like to invite Dr. Mansi Jain, who is consultant reproductive medicine gynae endoscopic surgeon at KJ IVF and Laparoscopy Center, national coordinator ultrasound. She has done fellowship in reproductive medicine from Thompson Fertility Center. She is a keen academician and has keen interest in research and in reproductive medicine. She has presented many papers and was the organizing secretary of pre-conference workshop AOGD 2000.
Good afternoon to all. I'm Dr. Mansi Jain, and today I'll be speaking on the topic tips and tricks of surgery in endometriosis, the mild and the moderate disease. So when we talk about endometriosis, we all know it's a very notorious disease. Starting from the diagnosis, the treatment and the post-treatment follow-up. It is a disease of complexities and controversies, dilemmas and debates. It is not a malignant disease, but it does behave like one at times because of its recurrent and progressive nature. Laparoscopy remains to be the gold standard when we talk about diagnosis and treatment of the disease. However, diagnostic laparoscopy alone is not recommended. We have level 1 evidence which clearly state that ablation, fulguration, cystectomy, radialysis, when done laparoscopically, definitely improves the overall pregnancy rate, decreases the recurrence, and also provides better results in pain management as compared to diagnostic laparoscopy alone. So when we talk about surgery, the main aim of the surgery is to restore the normal anatomy, restore the normal tubo-ovarian relationship, and minimize the disease to the maximum extent, except for large nodules or large lesions. And of course, we can do a total cystectomy or cystectomy with a combined approach. So the main aim is to restore the normal surgical anatomy and you fulgurate all the endometriotic lesions, minimize the disease as much as you can, and make the internal milieu more favorable towards pregnancy. And of course, increase the disease-free interval. So the second clip is a very typical case of grade 2 endometriosis. You will notice there are flimsy adhesions in the POD, and you can see the multiple endometriotic lesions scattered all over the pelvis. So it's very important to meticulously scan the entire pelvis. You need to look at the anterior surface of uterus, the posterior surface, the fundus, the anterior pouch of Douglas, the uterosacrals, both the adnexas, and also you must make it a point to lift the ovaries and inspect in the ovarian fossa as well. Because like I said, when you enter inside, you have to take care of the disease as a whole and treat it, minimize all the lesions that are there. So usually fulguration is preferred. Laser vaporization can also be done. We mostly use ablation with bipolar. A couple of things one must keep in mind while using bipolar. Firstly, you need to use low power current, around 30 to 35 watts, and low voltage current. Another thing that is important is you should give short intermittent bouts of energy rather than giving prolonged continuous bouts. And as you can see, the ovary is adherent with these flimsy adhesions over the posterior surface of uterus. So before you proceed for cystectomy, and total cystectomy is always preferred as compared to drainage and fulguration of the cyst. And this is irrespective of the size of the endometrioma. So whatever be the size of the endometrium, the treatment of choice remains to be total cystectomy. This of course comes with the inherent risk of losing the normal healthy tissue and decreasing the ovarian reserve. So it's always wise to get a serum AMH level done and counseling the patient both before the surgery and after the surgical procedure. It's very important. Then you have those cases when the woman may be above 35 years of age or has had a previous surgery or the AMH is already low. So those are the cases it's better to go for IVF. When you are actually doing, when you're already inside and you are doing laparoscopic surgery for such a patient, so there are options like you can go for the combined approach, do a partial cystectomy and do fulguration. So these are the cases where there are no clear-cut guidelines, but as a clinician you need to make the right decision. Cystectomy is usually done with the stripping approach. So what we basically do is firstly you need to free the ovary. If there are any adhesions, so it gives you the advantage that the ovary is visible and helps you in better dissection. Or you can go for blind dissection, or you can use sharp dissection, and you can also use hydro dissection. So stripping technique, I'll switch over to the other video which shows it better. Basically what you need to keep in mind is when we talk about endometriomas, it is very important to find the right plane of dissection. If you are not in the right plane, you ultimately end up damaging the normal ovarian tissue. So once you are in the right plane, you have to be gentle, you have to use the right amount of force, and you will notice once you get that right plane, it becomes really easy to strip off the wall of the endometrioma. It almost all comes So you need to put traction and counter traction at the same time, and then you pull out the cyst wall, and then you take care of any bleeding points. You can use fulguration. So that is a technique for large endometriomas. What we can do is large endometriomas which are taking up most of the ovary, and the ovarian tissue actually is very less. So we can do a tissue sparing surgery, where what we do is we do a partial cystectomy and leave the cyst wall, little part of the cyst at the hilum. So these are few ways to try and preserve the ovarian reserve. But again, all this varies from patients to patients, and depending on the condition when you put in your laparoscope, so you have to make your decision then. Talking about the risks of the surgery, we all know the most dreaded risk is the losing the normal ovarian reserve. We've already spoken about that. Then there is risk of recurrence. So for that, like I said, total cystectomy is always preferred. The chances of recurrence are much less. And then there is injury to the adjacent structures. Also, another thing I like to highlight here, so when you plan a patient for surgery for endometriosis, you must, according to the ESHRE guidelines, you must give the patient a fair trial of 3 to 4 cycles of IUI. One should not wait for an expected management after performing surgery for endometriosis. So that is another important thing we need to keep in mind. And so basically I like to sum up here the important points of the surgery. Good surgical skill is essential. You need to have a very good knowledge of the anatomy to be able to restore it. And again, total cystectomy preferred versus drainage and fulguration. Low voltage current to be used. Definitely don't leave these patients for expectant management. You should give them a trial for IUI, and that's the reason you should also do a chromoperturbation when you're performing the surgery. And the most important thing is good surgical skill. You need to be a trained surgeon to deal with endometriosis, because at the end of the day, it's a fertility enhancing surgery. And most importantly, you should know, a good surgeon should know when to stop. Thank you.
And grade 4 endometriosis, I would like to invite Dr. Kuldeep Jain sir, who is laparoscopist, infertility and IVF consultant, director KJ IVF and Laparoscopy Center at Delhi, founder, secretary and past president Indian Fertility Society. He was chairperson Endometriosis Committee of FOXI, scientific committee member 2019-22 and board of directors IFFS, organizing secretary of IFFS 2016. Formerly reader at UCMS and GTB Hospital.
On this afternoon, and thanks to Dr. Pankaj, whom I have been associated for long now, and we share a special bond, I can say. I must congratulate him for whatever he is doing. He is very thorough professional, and whatever he does, we have done a lot of programs together, lot of teachings together, and whatever he takes up, he is into it. So that is the great congratulations, Pankaj. I must thank Dr. Kavita for inviting me here to share my experience as far as the endometriosis is concerned. Mansi has already highlighted the problems. I will be sticking my talk to infertility related surgeries, though there are a lot of other areas which we can cover, but because of the time limitation, I will restrict my talk to advanced disease of endometriosis in infertility patients. Over the period, actually the guidelines and management issues are sorted out, but as previously also highlighted, that endometriosis is such a disease of complexity, and there are always debates whether it is the diagnosis, follow-up, treatment, management, whatever you are doing, there are always debate. Even in ET pathogenesis, there is a lot of controversies. Still, we don't know what is the exact cause of endometriosis, and that is the problem. We are not able to find out the right solution. A lot of options available, but when it comes to infertility, medical management is really having very limited role in infertility to improve the chances of conception, because you are suppressing the disease, and during that time you cannot offer any treatment, and patient is coming to you for treatment. So that is the limitation, and even after that patient is completed, the fecundity rate has not increased over the periods. So that's why the role of medical management remains very limited in endometriosis and infertility. So we are left with surgical management and IVF. So you have to decide as a surgeon, as a service provider, whether this patient is going to benefit with your surgery or not. I am not going into the debate whether the IVF is preferable over the surgery, but once you have decided the surgery and you are dealing with grade 3, grade 4, so I will be focusing on that. As a IVF consultant or as an infertility consultant, what are the points which you must keep in mind? That is very important. When you are putting a scope, you are having a bilateral endometrioma or a endometrioma with a lot of bowel adhesions. What should be your approach? And this is very important. This is now in the guidelines also. Put a scope only when it is required. So that is one thing. Grade 2 recurrence rate is not very high. After surgery, if you have done a good job, then recurrence rate should not be there. But still, even in grade 1, grade 2, after 5 years, 5 to 10% may have a recurrence. But as you advance, grade 3, grade 4 disease, the recurrence rate are as high as 20 to 30%. And the duration decreases. So recurrence rate, you have to keep in mind when you are dealing with the advanced disease and complications. Now, as you advance in the disease, the bowels are going to come into way. The bladder you have to dissect. Sometimes ureter you have to deal with. So complication rates are high, and you have to minimize the complication. You have to learn the technique to minimize the complications. These three things are very important for any surgeon who is dealing with endometriosis. Minimize the ovarian damage, minimize the recurrence, and minimize the complications. Now this is a case of bilateral endometrioma, large endometrioma. You see there are a lot of adhesions and whole POD is obliterated. This is very common picture. The severity of the adhesions may differ, but usually when you are dealing with a bilateral endometrioma, you will have such type. You cannot think a bilateral endometrioma not having any adhesions. Thing is stripping. See, Mansi is already highlighted. Now, stripping constitutes two important things. You have to find out the plane. Many times the plane is very easy to get. Many times you have to struggle to find a plane, especially in those cases where there is a recurrent endometriosis. There are the thick adhesions and you may not be able to find out the plane very easily. Once you find the plane, your traction should be at 90 degrees. That is second important point. When you are stripping the cyst wall, it has to be at 90 degrees. If it is at an angle more than 90 degrees or less than 90 degrees, usually you will not be able to strip it well, and there will be ovarian damage more when you are not stripping it properly. To minimize the best blood loss, Nowadays, this is a little older video. At that time, I was not using vasopressin, but over the period, we have started using vasopressin to minimize the blood loss. And this is a very active disease. Here, when I started stripping, there was a lot of bleeding. Usually, in older disease, you don't have bleeding, but when it is active disease and you are dealing with that, and that's why it is very important. All endometriosis surgeries should be done in post-menstrual phase. When you are doing the surgery in luteal phase, there are always chances of more bleeding as well as recurrence rate are very high. 20 to 30% risk are increased when the endometriosis surgery is done in luteal phase. So these are some of the important points that you have to remember. Now here you can see the bowel is adherent to the left ovary. It is a small endometrioma, but bowel is there. And again, the traction direction is very important to avoid injury to the bowel. When you are having the bowel adhesions, we prefer sharp dissection. In chances of injury to bowel are more when you are doing a blunt dissection. This is the stripping. You can see there is a lot of bleeding in this case, and this is because it is a active disease. If you instill vasopressin, you can minimize the blood loss by 80%. So it is advisable in all active diseases you should use vasopressin. Second thing, in this patient, though the result was good, but here at the base you can see there is a lot of bleeding. So these are some of the patients where you can fulgurate the hilum by bipolar and strip the remaining part. So that is where you can minimize the bleeding and minimize the ovarian damage. And of course, after removal, you have to fulgurate all the points, bleeding points, to minimize the formation of hematoma as well as chances of infection. So these are some of the points again in these patients which you have to keep in mind. This is another case, endometrioma with bowel adhesion. Here only 20% of the endometrioma is visible, and from all sides the bowel is attached. Now this is something where this video shows actually the bowel sparing or tissue sparing surgery. So when you are having difficulty in dissecting the adhesions near the bowel, it is better to strip some portion of the cyst along with the bowel to minimize the complication. That is another tip when you are dealing with the adhesions which are very close to the bowel. If you are able to find out the plane, it is very good. If you are not able to find out the plane between the cyst and the bowel, then it is this is on the lateral side, and you always start your dissection from the lateral side, so you can go on separating the cyst. Yeah, this is the last one. So here you can see
affects the fertility, but it also is very painful. Lot of dysmenorrhea for the patient. The patient will come to you, doctor, give me relief of these pains. So we have to be very careful when we are talking about treatment of endometriosis, and we have rightly told how to take care of grade 3 and stage 4 endometriosis and still preserving the fertility of the patient. The tricks and tips are well taken, sir.
Thank you.
We are so thankful, Dr. Kuldeep. Yes, please, ma'am.
It was a beautiful lecture, Dr. Kuldeep. You have covered everything. Just 2 points from my side. You know, when you do surgery for endometriosis, so now for the second session. For the second session,
panelist Dr. Prachi Panera, Dr. Vandana Sodhi. Dr. Renu Mishra is not here, she is sick. Dr. Bindu Bajaj, Dr. Sunil Mohan, Dr. Shalini Chawla. We are going to talk about infertility and endometriosis. What is the prevalence of endometriosis? We have been listening 5 to 10%, going up to 20%, and 20 to 30% in women diagnosed with infertility, 40 to 60% in women diagnosed with chronic pelvic pain. And what are the biological mechanisms that might link endometriosis with infertility? That is what we are sitting here and talking. What is the link between endometriosis and infertility? You have distorted pelvic anatomy. Dr. Kuldeep can explain very well. That once you put in a scope, you have to first is to have you have to reset the pelvic anatomy. You have altered peritoneal function, altered hormonal and sex-mediated function, endocrine and ovulatory abnormalities, impaired implantation, oocyte and embryo quality, abnormal uterotubal transport. So all these are various things from which endometriosis can cause infertility. And the challenges in endometriosis is a low ovarian reserve. Basically, it is a chronic inflammatory disease, and it is affecting both the ovaries and uterus, causing a lower ovarian reserve, a poor oocyte quality, and an impaired implantation. That is what is troubling us. We go to the case 1. A 28-year-old woman presenting with inability to conceive for 3 years. The investigation AMH 3.1 has specimen is normal, HSE bilateral petting tube. She has taken Promethazine 4 cycles with time intercourse over a period of 1 year. Will you consider laparoscopy in her case? Doctor, what do you think?
I would have a different opinion. I would first do a laparoscopy, find out if there is any other reason which our eyes can't see, the laparoscope can see, and then do an IUI for her.
Dr. Sunil.
So, unexplained infertility means she's been trying, she's been ovulating, she's been having the intercourse at the right time. So, if I do an IUI, I would definitely use gonadotropins with it. And if I'm using gonadotropins, I think I would like to scope her once just to make sure she doesn't waste her money. However, I also feel that what Bindu has said has some logic. Both answers are right, but yes, what she now requires is an IUI with gonadotropins. And if we are using gonadotropins, I think I would like to scope her to see that can I improve the results when the patient is spending on gonadotropins.
So what you say, you will do laparoscopy also?
I will do laparoscopy.
I just want to ask the hall.
Although there are studies which say that unexplained infertility, they have not really found anything much post laparoscopy, but I think I would like to do a laparoscopy.
I like to ask the endoscopist sitting in the hall. What do you think? That you want to put in a scope?
Then my mode of line of management would be to go in for a laparoscopy. Because in unexplained infertility, certainly there is a high incidence of endometriosis, maybe grade 1 or grade 2, and if we fibrate those lesions, certainly the chances of conception increases naturally after the laparoscopy.
It is actually the question is how you are defining an unexplained infertility. That is very, very important.
She is married for 3 years.
No, she is married for 3 years.
And use her patent, semen is normal.
Scope, correct or confirm the diagnosis and then go for IVF. So that is how I will decide.
And we have been doing it and we stopped doing unnecessary laparoscopies from past 5 years and the results have not come down. So we should avoid doing laparoscopies unindicated.
Yeah, so unless it is not indicated, you should not.
I think you should give her 3 cycles of IUI.
Yes.
And if she is still not conceived, then put in a scope. Isn't it?
3 cycles of IVF, it does not conceive, I would put a scope positive.
That's great. You see, we come to a conclusion. And we ultimately put a scope and operative findings were endometriotic spots on the posterior surface, uterosacral ovarian fossa which were fulgurated. Dr. Mansi has explained that this folliculation is better. Bilateral tubes and ovaries are healthy with a normal tube-ovarian relationship, and bilateral spill was also present. How you will consult? You have done a laparoscopy. These are the findings. Perfect. What is the role? How you will counsel the patient?
So it is very important to tell the patient that now the patient should be very aggressive in trying. There is no point of giving a break or giving suppression for a long time. Rather, we should go ahead with ovulation induction and IUI in the same cycle.
Coming to the second case, we have a 32-year-old lady who is presenting to us with primary infertility since the last 3 years. Her ultrasound pelvis reveals a 3 centimeter endometrioma. Dr. Bandana.
Despite being a hardcore laparoscopic surgeon, I will still not do a laparoscopy for this patient. Right? I will not remove the endometrium. It is advisable now not to do that and go in straight for an induction of ovulation and try an IUI.
If we find that the endometrioma is posing difficulty in our oocyte retrieval, then obviously it can be removed prior to going ahead with IVF. Also, I would like to say that it is very important to counsel the patient that any surgery on the ovaries can lead to ovarian reserve. So it's a very tricky call, but yes, patients should be thoroughly counseled before we do anything.
After surgery, go for 3 cycles of IUI. If it is ovarian relationship are maintained, it is a mild disease or moderate disease, go for 3 cycles of IUI. If patient doesn't conceive, go for IVF. If grade 3, grade 4 disease, minimize the disease burden and go for IVF if the patient is for fertility.
Basically, you see what is written, it is 12 to 18 months for a younger age group patient, very younger age group with a good ovarian reserve.
Sir, don't convert a mild disease, moderate disease to severe disease and then go for IVF or any other disease. It is a progressive disease. The number of cycles patient continue to bleed, she will be going from mild to moderate disease to severe disease.
It will take time. It will take time.
I think with the help of these practical problems, we were able to gain a lot of insights into how to go for management further. Thank you so much, sir. Thank you so much, all the panelists.
Thank you everyone. I will request Dr. Minu to honor our moderators and the panel experts with the practice.
Journey towards parenthood with Birla Fertility and IVF.